Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today in this review lecture video, we're going to be looking at intercostal chest drain. If you haven't yet subscribed to the channel, please subscribe to the channel. Hit the bell notification icon to be receiving notifications every time I post such videos. Grab your piece of paper, grab your pen, and let's go. When you talk about intercostal chest drainage, it can also be referred to as a chest tube. You can also call it as a thoracic catheter. You can also call it as a tube thoracostomy. Remember that this is going to be a conduit or a pipe or a tube that's going to be inserted through the chest wall and into the pleural space to remove either air, which is obviously referred to as a pneumothorax, or fluid from the pleural cavity, which is obviously known as a pleural effusions. So remember that the fluid can either be blood. We specifically refer to that as hemothorax, often associated with trauma. It could be due to infections, so pus can accumulate there. You refer to that as empyema thoracis. It could be chyle, which is lymphatic fluid. You refer to that as chylothorax. And of course, these are pleural effusions. So for the chest drain to actually be efficient, it must allow for re-expansion of the underlying lungs. It must also prevent any further entry of air back into the pleural space or drainage of the fluid back into the pleural space. Now, before you understand this, you need to note that the ICD actually has three main components for it to be working. It has to have an unobstructed chest tube, it should have a collecting container below the chest level, and there should be a one-way mechanism, so either an underwater seal or a Heimlich valve. Before we actually go into the details of the ICD, it is paramount that you remember some of the surgical anatomy that you learned back in your preclinical sciences. Remember that you have spaces in between the ribs, which are known as intercostal spaces. And these intercostal spaces lie adjacent to each of the ribs, and they're going to be filled with intercostal muscles. You have external intercostal muscles, internal intercostal muscles, and innermost intercostal muscles. And you also have an intercostal neurovascular bundle that is going to be laying in the costal groove along the inferior margin of the rib. And it's going to be passing in the plane between the inner two layers of the muscles. So from above going downwards, you have the vein, which is most superior, the artery, which is in the middle, and the nerve, which is at the bottom. And often the nerve is unprotected by the groove, so it means that this gives us an indication that it makes it very easy to give intercostal nerve block at this level. So you can simply apply some local anesthetic to this area. And also note that ICD insertion should be along the superior surface of the inferior rib, because if you insert it along that area, you're avoiding the nerve, which is usually found on the inferior surface of the rib. So you also really need to note that you have a demarcation between the thorax and the abdomen that is known as the diaphragm. And remember that the diaphragm is balloon shaped, and the right dome of the diaphragm is often higher than the left dome of the diaphragm. And on the right side, it can even reach as far as the sixth rib, which is why the ICD must be inserted above the sixth rib. It shouldn't be inserted below the sixth rib, because once it is inserted below the sixth rib, it carries a higher chance of abdominal visceral perforation. You may actually go into the liver. So here's an image of the surgical anatomy I have been explaining. So on the left of your screen, I know the diagram may not be of so much good quality, apologies for that. So you have the skin, which is the outermost layer, and you should know these layers which you go through when you're inserting the ICD. So you have your skin here, which is the outermost layer. You have your superficial fascia, which is just underneath there. Then you have your serratus anterior on the anterior aspect. You have the external intercostal muscles. You have the internal intercostal muscles, and you have the innermost intercostal muscles. And then of course you have the periosteum, which is covering the ribs. You have the neurovascular bundle over here, your intercostal vein, intercostal artery, and intercostal nerve, as well as some collateral branches. You also have the parietal pleura, which is adherent to the inner surface of the rib, and you have the visceral pleura, which is adherent to the lungs, and you of course have the lungs underlying there. And then in between the parietal pleura and the visceral pleura is this potential space which we refer to as the pleural space. Then on the other hand here, we can see the dome of the diaphragm. Of course, here we have your esophageal opening and the opening of the aorta. You have the whole diaphragm as a muscle. You have the left dome of the diaphragm, which is much lower than the right dome of the diaphragm. And of course, the central tendon, and here are the ribs depicted on this picture. Now, there is this teaching that goes and emphasizes on the triangle of safety. So you have your demarcations, which are pretty much the anterior border of this triangle is made up by the lateral edge of the pectoralis major. The posterior border of this triangle is made up by the lateral edge of the latissimus dorsi muscle, and of course the border of the fifth rib, or rather the fifth intercostal space. So insertion of an ID through this triangle of safety ensures that you can actually insert the ICD rather with minimal complications, but ideally it should be placed in the fifth intercostal space, mid-axillary line. So some indications for ICD insertion include pneumothorax. Of course, this should be recurrent. It should be persistent. It could be due to traumatic causes. It could be due to large, even tension pneumothorax, and if the pneumothorax is bilateral, or if you have a patient that's on positive pressure ventilation and they develop a pneumothorax, that would be an indication for an ICD insertion. You could also have symptomatic, recurrent, or even massive pleural effusions. There could be chylothorax, which is lymphatic fluid. It could be empyemothoracis, which is pus. It could be hemothorax, which is blood. It could be hydrothorax, which is serous fluid. And of course, in some post-operative procedures after a thoracotomy, a esophagectomy, as well as a cardiac surgery. Some contraindications to insertion of an ICD include conditions like refractory coagulopathies and bleeding disorders, diaphragmatic hernias. You may also have scarring in the pleural space, which of course are adhesions, as well as hepatic hydrothorax. When it comes to the mechanism of the ICD, I'll take you back to some of the principles that you learned in chemistry and some of the principles that you learned in physics. So remember that air is going to be a mixture of these gases. It's going to contain nitrogen, which is at a percentage of 78%, oxygen, which is at a percentage of 21%, argon at a percentage of 0.93%, and other gases at 0.1%, including carbon dioxide, which is at a percentage of 0.04%. And remember, according to Dalton's law of partial pressures, it states that the total partial pressure of a mixture of gases is going to be equal to the sum of the individual partial pressures of the constituent gases that make up this mixture. So remember that air is a mixture of gases, and remember that the normal atmospheric pressure is around 760 millimeters of mercury. So it means that oxygen is going to have a certain partial pressure in this component of the atmospheric pressure. So remember that oxygen is 21%. So if you calculate 21% of 760, oxygen accounts for about 159.6 millimeters of mercury. So that's roughly about 160 millimeters of mercury. And remember that the concentration of oxygen in the air is not the same as the concentration of oxygen underwater. Even the composition of air is not the same outside water as it is underwater. So it is much less underwater. Therefore, there's going to be a much less partial pressure in the oxygen. There's going to be a less pressure of air in underwater. And remember that this is then going to enable air to move from a region of high pressure to a region of low pressure. So that's with the physics and the chemistry. But now let's get to the physiology. So remember that inside the pleural space, you have a negative pressure that enables your chest to expand. And remember that normally at rest, the pleural pressure is going to be subatmospheric. So it means about less than 2.5 millimeters of mercury below the atmospheric pressure. And the reason why you have this negative pressure is so that you can create a suction mechanism such that air is going to be flowing from the environment, a region of high partial pressure, to inside the lungs, a region of low partial pressure, helping in the expansion of the lungs. But however, this pressure that's present in the pleura is also even much less than the pressure that's going to be underwater, and therefore this fluid or this air that is trapped in the pleural space can easily flow from this area in the pleura into the fluids from an area of high pressure when it starts to accumulate in the pleural space. Because remember, if you have fluid or air accumulating in the pleural space, it's going to increase the partial pressure in the pleural space. So it means that this pressure in the pleural space is going to at a point even exceed or rather balance with the atmospheric pressure. So therefore this fluid is going to be flowing from the pleural cavity into the underwater seal, and it's going to be draining out. So the air is going to be bubbling through the water seal to the outside world, and of course the length of the drain below the fluid is very important. So if it's greater than 2 to 3 centimeters, it increases resistance to air drainage. So here is an example of a simple ICD mechanism. So you have this tube that's coming from the patient. It's going to be underwater here. You have this, which is known as the meniscus. And then, of course, you have this tube, which is, of course, connected to air or can be connected to suction. Then equipment that you actually need for an ICD include the following things. You need sterile gowns, you need a mask, you need gloves, you need drapes. You also need petroleum-based and regular gauze dressing and some adhesive tape. You also need a cleansing solution, so povidone iodine and methylated spirit. You need 25 and 21G needles. You need a 10 mils as well as a 20 mils syringes. You also need local anesthetic. We can use 1% lignocaine. If you do not have this, you can actually use 2% lignocaine, but make sure you dilute it. Then you can use also 2 hemostatic clamps as well as Kelly clamps. You may also need non-absorbable strong nylon sutures, either 0 or 10, a scalpel with a size 11 blade, and of course a chest tube with its connecting tubes. So the chest tubes actually range in different sizes. They can range from 16 French to about 36 French in size, and this obviously depends on the use that you want to use these tubes for. So for a pneumothorax, you can use 20 to 24 French size of a tube. For a malignant pleural effusion, you want to use also 20 to 24 French. For complicated parapneumonic effusion, you use 28 to 36 French. For empyema, even for bronchopleural fistulas, you use 28 to 36 French tube size. And then, of course, for hemothorax, you use a 32 to 36 French tube size. Then you also need suction and, of course, a water seal drainage apparatus and connecting tube. Then take note that you can actually find most of these instruments in an excision set, especially the clamps, the scalpel, the drapes, and of course the sterile gowns. And you should also get some sterile chest tubing and the apparatus, the underwater seal. You can actually make an underwater seal or improvise an underwater seal. And obviously, this goes without saying, you actually need an assistant to be present because you can't really do this alone. So here's an example of the different needles and different colors. The ones that you need are obviously a 25G and a 21G. So 21G and a 25G. But obviously, I haven't seen most of these needles on the wards, and what we usually have on the wards are the green needles as well as the blue needles. And here's an example of the Kelly clamp over here, and of course a hemostatic clamp. And when you actually look at the chest tubings, they are actually going to be made up of clear plastics such as PVC, polyvinyl chloride, or soft silicone. And these conventional chest tubes have these multiple holes or fenestrations in them, and they have a section of the tube where there's a marker such that it gives you an indication of how long of a distance you should actually go. And in addition to this, there's going to be this radiopec strip that outlines the first drainage hole, and it allows you to be able to visualize this tube on the x-ray. And the number of holes usually varies, but generally you have 6 on most of these chest tubes. So we'll look at the principles of chest drainage INSERTION. Remember that unless if it's an emergency situation, then you should always order for a pre-procedure chest x-ray. Then you should ensure that the person that's going to be inserting the ICD has been trained to do this. And if you are suspecting a pneumothorax, you may perform an emergency procedure which is known as a tension a needle thoracostomy with a tension pneumothorax. So this needle thoracostomy, you just get a 21G needle, and then you go a mid-clavicular line into the second intercostal space and go straight into the second intercostal space. You will have some pressure, and then eventually there will be a giving, and of course there will be some relief to the patient. Then the chest tube insertion is, of course, an inpatient procedure. So it means that if it's done in the emergency department, you should ensure that you actually admit the patient. You can't do it an ICD and send the patient home because they may not know the do's and the don'ts of the ICD at home. And of course, there may be other complications that may ensue. So the drainage is actually inserted under local anesthesia, and it's done with aseptic technique, and the drain is supposed to be inserted over the upper rib of the border, or the upper border of the rib rather, to avoid any damage to the intercostal vessels, to avoid any damage to intercostal nerves. So the preliminaries that you have to ensure is that the patient should actually be informed of the procedure. There should be a written consent that should actually be taken. You should prepare the adequate materials, the ones that I just listed for you in a few slides earlier on. You should position the patient, and you should be able to mark the site. And of course, you should have some oxygen saturation monitoring close by, as well as an oxygen supply that is very close by. Then you should also connect the water seal apparatus with sterile water to a source of suction. And then, of course, this is the simple mechanism that I showed you earlier on. So how is the procedure itself? So if it's a patient that's spontaneously breathing, you want to have the head end of their bed elevated at an angle of about 30 to 60 degrees. If they can sit, that would be even ideal. Then this is, of course, done to limit the elevation of the diaphragm. That's obviously going to be occurring during expiration, and therefore this is going to be decreasing the risk of you inadvertently placing the tube into the abdomen or perforating into the diaphragm. And the arm of the patient on the affected side may actually be even placed over the patient's head, or otherwise it should be abducted. Different positions that may be present. So part A here is the most ideal position. The patient can be seated and put their arm over their head with, of course, their arm abducted, or they could lean over a cardiac table, or they could be lying on the lateral position. But of course, the most ideal would be seated with their arm abducted over their head. Then you should be able to mark the incision site. So the incision site is going to vary based on whether it's air that's being drained or based on whether it's fluid that's being drained. Generally, for a pneumothorax, remember we talked of the triangle of safety, which is marked by the superior border of the fifth rib, or rather the sixth rib, and the anterior border is going to be the pectoralis major. The posterior border is going to be the lateral border of the latissimus dorsi. So you have this triangle as a triangle of safety. So if you have a pneumothorax, you can insert the tube in the fourth intercostal space, mid axillary line. If you have other indications, you should insert it in the fifth intercostal space, obviously in the mid axillary line as well. So you should mark your insertion and prepare the skin and clean the skin with povidone, and then of course use methylated spirit and allow it to dry. You could actually even use a combination of Savlon, iodine, and methylated spirit. And then of course you should drape the site with fenestrated sheets or some dressings that are sterile that you get from theater. Then you should inject a local anesthetic, like for example 1% lignocaine, into the skin, the subcutaneous tissue, the rib periosteum, that's of the rib that is below the site where you're going to be making your incision, and of course into the parietal pleura. And you should inject large amounts of local anesthetic around the highly sensitive periosteum as well as the parietal pleura, because these have a lot of nerve endings and they could cause this patient a lot of pain. And you should aspirate before you actually inject your local anesthetic to ensure that you're not in a blood vessel, because if you inject lignocaine into the blood vessel, you may bring about other problems that you do not want to see. Then the proper location is obviously going to be confirmed by air getting into the syringe as opposed to blood. And then of course, if you ensure that you're not in a blood vessel, you can start infiltrating within these structures and depositing the local anesthetic. So you should also be able to estimate how deep the tube needs to be inserted so that the tube holes are all within the pleural space, and you should also be accounting for subcutaneous as well as fat tissue, especially in obese patients. And you should note or record the mark on the tube that should be visible at the skin, and you should note that, okay, this is where I'm going to stop advancing my tube. So here is an example of the different locations where we're going to be placing our anesthetic. So as you can see here, you have the lungs, you have the pleura here, and you have the different muscles, you have the neurovascular bundle. As you can see here, you're going towards the rib and anesthetizing the periosteum. You're going over the surface of the superior rib. So you're assuming that, of course, this is your sixth rib, and of course, this would be your fifth intercostal space. So you're going over the superior surface to avoid these neurovascular bundles. Then, of course, you should also deposit a large amount of anesthetic to prevent any pain during the procedure. So when you're making your incision, you should make sure that you make your incision 2 to 3 centimeters. So you make a transverse incision through the skin. You're going to be going through the subcutaneous tissue and the overlying intercostal space, and you should extend your incision by performing blunt dissection through the fascia towards the superior aspect of the rib that's above. And you can do this by actually advancing your closed hemostatic or Kelly clamp. I'll just call them as artery forceps. So you should insert your artery forceps, and then you insert a closed artery forceps, and then you open it, and then you do this as you blunt dissect through the layers, and you should be able to identify the rib below the insertion and move over the rib in order to find the pleural space above the rib. And then after the superior border of the rib is actually reached, you should close your hemostatic clamp, and you should turn this hemostatic clamp or your artery forceps and push it through the parietal pleura. Of course, there will be some resistance, and once you apply steady and firm and even pressure, you will feel a giving. You will feel a pop or a sudden decrease in this resistance. That means you're within the pleural cavity. So you should open the forceps widely once you're in the pleural cavity, then close it and withdraw it slowly. And when you're closing it and actually withdrawing it, ensure that the tip of the clamp doesn't actually perforate into the lungs or penetrate into the lungs, because it's very common for actually the tip of this forceps to actually go into the lungs and puncture the lungs. And then you can use your index finger, or you should use your index finger to make the tract a bit wider, and of course enter into the pleural cavity and confirm if there are any adhesions that are present. So here is the insertion of the artery forceps that's going to be inserted there, and of course will be opened. You insert it as it's closed, then you open it to make this tract wider. Then once you reach the pleural space, you open it as wide as possible, then close it and retract it out. Then you should ensure after you do this that you clamp your tube on the outside before you start to insert it. Then at the end of the tube, you should be able to grasp the tube with the tip of your artery forceps, such that the tube is actually going to be protruding just beyond the jaws of the clamp. And then you're going to be advancing this tube into the hole, into the pleural space, using your finger as a guide. And then of course, it is traditional teaching or old teaching that if you have an effusion, the tube should actually be inserted inferiorly and posteriorly. If you have a pneumothorax, it should be inserted apically until all the holes are inside the chest. But recent research has actually shown that despite the direction which the tube is facing, the fluid or the air that is present in this space is going to drain because of the difference in the partial pressures. Then of course you should advance the tube until the last hole is about 2.5 to 5 centimeters inside the chest wall. Remember the marker that you made on the tubing for the length? Yeah, you should be able to get to that length. So once the tubing is actually within the pleural space, you can suture the tube to the skin of the chest wall using one of many methods. So you can use what is known as a purse string. In addition to this, you're going to place an interrupted suture next to the tube across the incision and tie the suture around the tube. Another method is to actually substitute a secondary interrupted suture across the incision on the other side of the tube for the purse string suture and tie the suture to the tube. Then of course you're going to be placing the sterile dressing with petroleum gauze to help form a seal around the wound. You're going to be cutting 2 sterile gauze pads halfway across and place them around the tube. And then after this, you remove the draping and of course tape the dressing in place using pressure dressing. And then of course, to increase the stability, consider taping the outside part of the tube to the dressing, and or to the patient separately. Then ensure that you connect this tube to the underwater suction apparatus to prevent air from entering into the chest through the tube, and of course to allow drainage with or without suction, depending on whether you're going to be connecting it to a suction machine or you will not. So here is an example of a purse string and an ICD that is in situ. So you should confirm the position of the ICD. And how do you confirm this? You confirm this by visualizing the column or the meniscus moving with the tube within the tube as the patient is respiring, or by the draining of the fluid that's going to be seen within the tube. You can also ask the patient to cough, and you should observe that there are some bubbles that are going to be forming at the water seal level. And if the tube has not actually been inserted properly, no fluid is going to be draining, and the level of the water column will not vary with respiration. If all these preliminaries are checked, after confirming the position of the ICD, you can actually do an anterior-posterior chest x-ray to check the tube position. And if there are any concerns about the positioning and the functioning of the tube, you may actually do a posterior-anterior and a lateral chest x-ray. After the procedure, you should ensure that you document the whole procedure in the patient's file. You should report the x-ray findings. And of course, there should be some ICD care details that are taught to the patient or instructions that are put in your plan. So remember that you should always keep the ICD below the chest level. The chest tube should be secured to the chest wall with your suture. And then, of course, the ICD bag must be filled with sterile water up to the marked line. If you insert this ICD, you should report if there is any continuous bubbling or continuous blood or intestinal content that is present in the tube. Then you should encourage the patient to keep coughing and have some chest physio. So give this patient a balloon that they're going to be inflating intermittently so that their lungs can inflate and deflate to help with the drainage of the fluid or the air in the pleural space. Because remember, as someone expires, the pressure in the pleural space increases. So this increase in the pleural pressure is going to be forcing whatever is in the pleural space to exit through this ICD. Then, of course, you should also offer some pain management and respiratory exercises, daily auscultation of the chest, monitor the oxygen saturation, and of course, check the local site for presence of subcutaneous emphysema, which is air in the subcutaneous tissue. Then some warnings and common errors that are often noted with ICDs. So the water seal suction apparatus must be kept 100 centimeters below the patient to avoid, of course, retrograde flow or even siphoning back of the air into the pleural space. And some clinicians actually recommend that you shouldn't drain more than 1.5 liters of the pleural fluid in 24 hours because there is this concern that the patient may have what is referred to as re-expansion pulmonary edema. Even though there is very little evidence that there is a risk of re-expansion pulmonary edema that's going to be proportional to the volume of fluid that is removed, some clinicians still shun away from draining more than 1.5 liters in 24 hours. Then, of course, if the chest x-ray is showing that the tube is not advanced far enough and the aspiration holes of the tube are actually not in the chest cavity, do not simply push the tube inside. You should insert a new tube, because if you push the tube inside, you're introducing a new infection, or rather you're introducing a non-sterile part into the pleural space. And remember that the pleural space is a sterile area. Then some common insertion errors include inadequate quantities of local anesthetic that are administered, and of course making an initial incision that is too small. You should also ensure that you lock the stretcher or the bed that the patient is on before inserting the tube, because insertion of the tube may require significant force and it may cause the stretcher to move. So some tips and tricks that you can carry with you is, remember that you may perform some conscious sedation prior to the procedure in selected number of cases. So you may give some sedatives, just some mild sedatives, not severe sedatives. Then you may also mark the incision point using a skin marking pen, or make an impression with a pen so that the skin cleansing preparation will not remove the mark. So here are some of the do's and don'ts of chest drains. So avoid clamping the drain, as this can lead to tension pneumothorax. So the drain should only be clamped when changing the bottle or transferring the patient, and always keep the drain below the level of the patient, below the level of the insertion. If it's going to be lifted above the chest level, the contents are going to be draining or siphoning back into the chest. If a disconnection occurs, reconnect it and ask the patient to cough. And of course, you should see the meniscus moving. You should be able to see the bubbles. Then if there is a persistent air leak, you should consider low pressure suctioning, then observe this patient for post-expansion pulmonary edema. Then when it comes to removal of the ICD, this is obviously done when it has served its purpose. So if you have a pneumothorax, the suctioning is stopped and the tube is going to be placed in just underwater using an underwater seal. Then for several hours, you're going to be checking and ensuring that there is no air leak. And once this has stopped and the lung remains expanded, you can order for a repeat chest x-ray 12 hours or 24 hours after the last evidence of this air leak before you actually remove the tube. For pleural effusions or hemothorax, the tube is typically removed when you have a drainage of less than 100 to 200 mils in a day of serous fluid, so there shouldn't be any blood. Then when you're removing the tube, remember that removal of the tube in patients on mechanical ventilation, especially those that have high oxygen requirements, those that are on positive pressure ventilations, those that have chronic lung disease, or those that are at increased risk of pneumothorax, should be done only after consultation with a pulmonary specialist or a senior at least. And of course, to remove the tube, ensure that the patient is going to be semi-erect. After removal of the sutures, at the moment of removal, the patient is going to be asked to take in a deep breath, and you ask them to breathe in and breathe out forcefully. So when they forcefully expire, that is the moment where you should actually remove the tube. So you first undo the suture, then you ask the patient to take a deep breath out, and then when they deep breath in, then a deep breath out. When they are taking a deep breath out, that's when you remove the tube, and of course cover the site with your petroleum gauze. And this sequence is done obviously to reduce the chances of a pneumothorax happening on removal of the tube, because a pneumothorax can happen. Then of course the purse string, if it was actually inserted during the tube incision, it can be closed and additional sutures may be needed to close the incision. And a chest x-ray should be done several hours after the removal. And if, of course, there is no pneumothorax that's seen on the x-ray after the chest tube removal, then there's no further x-rays needed except those that are dictated by clinical changes in the patient's condition. So remember that when you're talking of complications of the ICD incision, this is a statement that I want you to keep in mind. So there is no organ in the thorax, there's no organ in the abdominal cavity that has not been pierced by a chest drain. So it means that virtually almost all the organs in the chest, most of the organs in the abdomen have propensity to be injured, and this is how. So some early complications include misplacement, so the tube may be displaced, the tube may be inserted too far, the tube may be placed subcutaneously. You can also cause subcutaneous surgical emphysema. You can have injury to organs and other structures such as the diaphragm, causing injury to the liver or the spleen. You may injure the lung. You may have pulmonary or lung lacerations. You may have parenchymal or hilar injuries. You may have injuries to the heart. You may have injuries to the phrenic nerve, injury to the neurovascular bundle, esophageal perforation. That's obviously going to lead to hemorrhage. You may have bowel injury in the presence of unrecognized diaphragmatic hernias. You may also have contralateral pneumothorax, hemorrhage, as well as hemothorax. Intermediate complications include surgical emphysema, re-expansion pulmonary edema, tube blockage, and infection along the tube. Late complications include retained hemothorax, pneumothorax after removal of the tube, empyema, abscess formation, as well as fistulas. Thank you for spending your time to listen to this review lecture video on intercostal drainage. If you haven't subscribed, what are you waiting for? Hit the subscribe button. Hit the like button to help me with the YouTube algorithm. Share the page with someone who is studying for a surgery exam or someone who wants to revise on the intercostal chest drainage. Drop a comment to show some support. Thank you to Zambia and beyond. My name is Dr. Moses Kazevu.